I'm going to introduce Laura Gordon, who is a past chair of the National Forum and a communication strategist and principal of Laura Gordon Consulting. And Laura is going to focus on what comes next and driving change. The National Forum over the last several months has worked with partners to draft a call to action, and Laura will present that right now, and then we'll be eager to get your comments on it. Laura.
Thanks, John. And I timed my talk a bit earlier, and I believe I will be very able to give back some time so that if there are some questions that you want to answer later, I'm going to pledge to give you some of that time. So thanks to everyone. I'm so pleased to be part of this. And what my goal is in the time that I have is to um, walk us through the call to action, emphasizing that it is in draft form. We are very eager for more input. It has been put together with the input of some early listening sessions and some meetings, but we are very excited to have this larger group and to have a lot more input as we walk forward with it. I'm not going to I'm not going to read through all of the strategies and actions suggestions, but I am going to touch on them, provide an overview, and then share at the end what the next steps are and how we want to collect your feedback and that sort of thing. So with that, let's get started. So I will read the CTA, the main call to action, because I just want to make sure that we are all hearing it. It's brief, it's succinct. That was our goal. Keep it simple. So the call to action as currently read is increase early detection and treatment of kidney disease in people with hypertension, family history of CKD, cardiovascular disease and/or diabetes to prevent disease progression and improve people's health in all parts of the nation. So briefly stated, that is our overarching goal here. And the strategies John shared with you earlier, so I'm not going to read through each of them, but I did want to raise just a few important points that came up as part of the discussion as we were crafting these draft strategies. One is that, as you heard from many folks already, but wanted to reemphasize, when we talk about elevating recognition, we want to ensure we're reflecting a variety of care settings. So recognizing that many people at risk may get their primary care from less traditional settings, such as emergency departments, urgent care clinics, et cetera. And so pharmacies, give Ben his due. So when we talk about that first strategy and elevating recognition, that's a really important point we want to make sure we preserve and amplify. With regard to the second strategy, and again, this is something I'm so glad that you've already heard from our speakers. We are emphasizing that it is not just about screening, it is the follow through to diagnosis and treatment. And that can too easily fall through the cracks. We've got to make sure that there's an emphasis on that follow through in our call to action. So that's why you see it here. And so now I'll walk through our suggested tactical actions. If you want to go to the next slide, John Barkis, and talk a little bit about some of these in more detail, but for the most part, I'm just going to go over them in a more top line fashion, and in a few cases, like I say, suggest why they're there or where they came from. These actions, as I mentioned, were suggested during a series of listening sessions and initial survey we've conducted. Some are in the works right now, as you've heard from some of our speakers today, both the state and national levels. So that's amazing. So, our goal is always going to be to build on what's there, amplify successes and best practices. And after this meeting, I'll touch on this again. We'll be sending a survey to all of you asking for your input on these suggestions and any additional tactics that you think should be part of this. There's always room for more. Okay. So we'll start with strategy one. And again, we talked about elevating recognition. So what are the things that are going to do that? And when we first started this discussion, and as part of the listening sessions, there were more than a few people who said, education, we're doing it, been done. Like it's got to be more than that. We said, absolutely. Of course, it can't just be about education, but as we also know, you can't stop education, and there's never enough education, especially in this crazy world that we live in. So we really do see the need, of course, to keep the education going among the variety of audiences that are part of this process. So it absolutely should be continue to be or be part of medical and pharmacy school curricula. But we can also do more within the field education. You're already hearing that among pharmacists, nurse practitioners, community health workers, PAs. At the same time, we don't want to lose the whole piece about and continuing to work to empower patients. It should not be just on their heads. The clinicians are going to be the drivers in understanding what needs to happen. But the more we educate patients, the more we empower them, and we've got to support them along the way. So the information they need to help them seek the screening and ask about it, including through services such as community navigator programs that have been discussed. And of course, we should use technology. So we need to make screening and diagnosis the lightest possible lift. Keep it easy, keep it simple. So using EHRs to identify as at-risk patients in a practice, proactively bringing them into care, contacting them and saying, come on in, we need to talk. That can be done. There's a lot of automation. There's a lot of technology we can be leveraging. All right, let's go to the next one. So strategy two, okay, so we've done the educating, that's important, but how do we get clinicians to take action? How do we get them to screen properly, diagnose CKD, and treat it? So an obvious but still important tactic is to ensure that as many primary clinicians as possible are aware of existing screening guidelines. I still remember from when I was a medical reporter years ago that a study that came out that said that it takes about 10 years for a clinical guideline to get into practice, which at the time was just, I mean, stunningly bad. But I don't think that we've improved it much. So there's never enough education about guidelines, and especially when it's among primary care docs and other clinicians who have a lot to think about and a lot to juggle. So that awareness has got to continue. And going back to the strategy of making it as easy as possible, technology is our friend, again, with this strategy. So EHR prompts, standing orders for high-risk patients, and other workflow mechanisms. These can help make screening and, importantly, the diagnosis and the follow-up routine. Involving non-MD clinicians, this is a topic very near and dear to my heart. I've been involved with the pharmacists for many years. This can be an especially powerful action with this strategy. PAs, NPs, pharmacists are well positioned to be doing this screening in a variety of settings. And we'll talk a little bit more about the policies that are needed in some cases to support that. But these are clinicians who are eager to be part of this. They are seeing folks sometimes just at the pharmacy counter, not in a per se clinical setting, but a retail setting. So there are ways to be truly leveraging them here. It's what they want, and it's what will help patients. Right, next slide. And our final strategy, it's all about the policies. I'm not telling anyone anything they don't know on this call. We all know that in healthcare, especially now with providers stretched thinner than ever, especially if it's not reimbursed or otherwise incentivized, it is unlikely to happen. So when it comes to payers, we need to show them the money. We know there is a proven ROI, so it's critical that we amplify that evidence-based information for that audience. We also need quality measures that incentivize early kidney disease diagnosis and management. Establishing an ICD-10 code was also suggested as part of the listening sessions and surveys that we did to improve integrated care, measurement, reimbursement. Incorporating CKD prevention and management into CMS alternative payment models, that is a really promising opportunity and something that there's been a lot of discussion here and before this meeting. Another suggested action, and critically, we must ensure that policies, again, are supporting patients. We need pathways, whether it's telehealth or community navigation or other ways of reaching people most easily where they are, not putting the burden on them, but getting the information to them. But not just getting them information, but making sure they understand it. We're all still so guilty of providing information to patients that, I mean, I look at stuff and, I can't understand it. I've been in health for 30 years. So that's something we can never forget, that we've got to make it simple for everybody. So those are really the points I wanted to make with the actions. And again, we'll welcome your input. So where do we go from here? Very much looking forward to hearing your feedback on this draft call to action, whether it's the call to action itself, the strategies, the suggested tactical actions. So look for an email soon that will have a link that will enable you to share your thoughts. And we really are excited to have them. Following that, we will circulate an updated draft of the call to action that incorporates your input. And in the meantime, we encourage you to talk with your organizations, help them see, you can share the call to action with them, of course, there'll be slides to share, all the things we've discussed today, and have the discussions, especially where you may want to play a role as an organization. And as we move forward to finalize the call to action, we'll ask your organization to sign on. So look for that as well as we move forward with this path. So I just wanted to say to close that we're just thrilled at the interest that we've seen to date, the time people have already given so generously to help us get to this point today. And we are very much excited to see where we go from here and get your feedback moving forward. And with that, I will hand things back to John.
All right, Laura Gordon, thank you very much. That, as you promised, that was a crisp and clear presentation.
4 minutes back.
There we go. We appreciate that. And it's exciting to have the call to action on the table now. So the call to action is important because, as we saw with the joint policy statement that I referred to earlier, we heard from legislators, from policymakers in different state houses that seeing a large number of diverse stakeholders come together behind a set of recommendations really made an impression on them, and in many cases caused them to take the policy proposals more seriously or to give them greater consideration and then ultimately to enact them. So, goal one here is to enable as many organizations as possible to be comfortable in signing the call to action, becoming part of it. And just the act of signing it will give your organization power to affect change, and it will lend the overall effort power from your organization because your organization's signature carries weight with decision makers, with policymakers. And the relatively simple, very low cost act of becoming a signatory enables you to be part of the action. Now, of course, a call to action needs to be answered, and we need many different players to play various roles in answering it and to drive the kinds of system and policy and cultural and communications and reimbursement policy changes. So we'll be looking for you to help identify ways that your organization can play on its strengths and not take on something new, but rather align the work that you already do and your strengths with the planks or pillars of the call to action so that it can help you achieve some of your goals and will create a rising tide here that won't just lift all boats, but more importantly, will drive change, as we said, a course correction for the healthcare system, and that will result in improved care for people throughout society and earlier diagnosis of kidney disease for people who are at risk, regardless of where they are in the United States. So, with that, I want to invite a few brief reflections from participants in today's convening. And I believe we have ready to go National Vice President from the American Heart Association, Alyssa Presley. Alyssa, I know you've been working on um, not only a presidential statement from AHA, but also a significant initiative. So we appreciate your being part of today's convening, and we're eager to hear your reflections.
Yeah, of course. Hi, everyone. Yeah, I think at high level, excited to see this work moving forward and, well aligned at its core with the cardio kidney metabolic health work of the American Heart Association. It's really all about earlier identification of risk, coordinated care across discipline, ensuring people don't fall through the cracks because conditions are managed in silos. And definitely see here that there is an emphasis that kidney disease does not exist in isolation. So very much appreciate that. Also, I see some strengths here that the emphasis is on routine screening, high risk populations. Primary care enablement is another thing, noted that is also, well aligned, and then clear, pathways from detection to treatment, reflecting, the cardio kidney metabolic approach that we are, taking as well. So appreciate the thoughtfulness in this and look forward to providing additional inputs and aligning to our work in the right ways.
All right. Thank you very much, Alyssa.
Yeah.
And I know I said earlier that AHA is on track to issue a new guideline on what is it, CKM syndrome in the second quarter. I don't know if you have any clarification on that or correction.
That is about all we can say. It's anticipated in second quarter, first guideline on CKM syndrome.
All right. Thank you. We will all keep a watchful eye. All right. Miriam Godwin, Vice President of the National Kidney Foundation. Thank you for participating today.
Course. I'm so delighted to be here with so many colleagues and friends to talk about an issue that has, as you heard from Elizabeth Montgomery earlier in the session today, something that we've been working on for years and years and years and years. And it is really, really gratifying to see so many people talking about chronic kidney disease and about what we can do to achieve system transformation around prevention, early detection, and early diagnosis of CKD. I'll just say that one thing that I often say to policymakers and to people when I tell them the story of chronic kidney disease is that, for a long time, we look to people with kidney failure to tell us the story of chronic kidney disease and about how important prevention and early diagnosis is to maintaining kidney health. And the reason that we can't ask the rest of people affected by chronic kidney disease is because they've died of cardiovascular conditions. Most, as you probably know, most people with chronic kidney disease will pass away before ever reaching kidney failure. And that is a story that does not need to take place. With the actions that we talked about today, awareness, teaching people about kidney health, getting that EGFR and UACR done and securing that diagnosis, we have unprecedented opportunities to preserve kidney health for people and to give them a different ending to the story. So when I get up to do this work every day, I think about those people who could never tell us their story and who never had the chance to learn about their kidney health. So I'm so glad that we're here to tell a new story, to talk about the opportunities that we have to change the trajectory for millions and millions and millions of people living in this country. And we know what to do, and now we just need to look for opportunities to scale that work. And I can't wait to do that with all of you.
Whoops. You'd think after these years, I would have figured out how to work the mute button. Thank you very much, Miriam. We appreciate your comments. Heartfelt. Love your the way you're answering a calling and the way that you shared your North Star. So thank you. And you were making me reflect on my experience with my father, who faced the heart-wrenching decision, at least it was heart-wrenching for the rest of us in the family, of do you go on dialysis with a pretty certain degradation of quality of life, or do you face the certainty of a shorter lifespan? That's a decision that so many people face every day in the United States, and that all of us here together have an opportunity to change. So we can do this. And what a great opportunity we have to join forces and make a difference. So I hope all of us will provide input on the call to action and then add our signatures, our power to it, and then join in taking action, answering that call. And we certainly appreciate what you're doing, Miriam, at NKF, what Alyssa and her colleagues are doing at AHA. I want to turn now to our friend Dr. Rob Starr from NIDDK. Dr. Starr, we appreciate your joining us for this convening today, and we're eager to hear your perspectives.
So thank you. And it's really hard to add much to what has been said, but I do want to amplify something that Miriam just said. And I want to say it a little bit differently to see if it lands differently. And that is that 90% of people with chronic kidney disease die before they get to dialysis, and they die of cardiovascular disease. So at the beginning of this forum, it was sort of, well, we're going to enrich, we're going to look in the CKD clinic and the cardiovascular clinic because that's where the CKD patients are. That's true, but as we've been hearing from the patients, from the people with lived CKD, when you look at it in that lens, it makes it even more imperative that we do something. And the good news, that there are two pieces of good news here that other speakers have said. One is that we have much better therapies than we had before. The ACE and ARBs are okay, but the SGLT2 and GLP-1 drugs and newer ones are much better, and they impact mortality. They keep you alive. It's not just keeping you off of dialysis, they keep you alive. And this is really good news. So if you're trying to devise a screening program, early detection program, you need a good treatment program. And I think we now have good treatments for kidney disease. Now, on the research side, we have this Kidney Precision Medicine Project, which is in the beginning processes of blowing up the current textbooks on chronic kidney disease. And we do plan to rewrite the textbooks. We're not quite there yet, but just to let you know that it's a large effort, that we've done about 700 biopsies or so, 100 or so in patients with acute kidney injury that we haven't even talked about here. But we're finding that acute and chronic kidney diseases, plural, are all mixed up together. And that doesn't change any of the larger picture treatment things and screening things that we're talking about here, but it will change some of the details. So I wanted to go through the plan a little bit, because it's very similar to one that Andy Narva had started here about 20 years ago, called the National Kidney Disease Education Program, which unfortunately was stopped about 10 years ago. That's an unfortunate discussion we could have later. But there are two or three things that I think are important. One was addressing, so the first sort of tactical thing that you come up with is education. And one thing that we noticed was that there's a fear of kidney disease, not just in patients, but in the providers. They don't understand how the kidney is, what it works, and what do these lab tests mean. And they're fearful of learning. And what the National Kidney Disease Education Program tried to do was help people past that fear by explaining things in lay language, very simple, to the clinicians. It helped the patients too, but it was an effort at clinicians. And we also knew, to your endpoint, what you call drive-by screening, that it was really important to involve the non-patients. So the disease education program spent a lot of time training dietitians, training pharmacists. They're good education programs out there that we developed. They need to be updated because they're like 10 years old at this point. But there were certificate programs that they come up with that were really important. They also did screening at churches, the Sundays, kidney Sundays. There were a lot of novel things that we worked on that you're hearing here that are important, and it is good to see the community now spreading out that message. I think that's so. And the other piece that I wanted to talk a little bit about was trust, because I think Tiffany mentioned that, and others have also. To me, that's one of the basic things that we need to be working on, is how to get people to trust the medical care system. The environment around us is very toxic to that message. And it's important that we can show people that we really can help you, that we really have strategies, new drugs, new ways of thinking about kidney diseases, plural, that can help you not just stay off dialysis, but keep you as a productive member of society. So I'll stop and take questions later.
Thank you, Dr. Starr. Really appreciate the perspective. Thanks so much for that strong and important reminder at the outset of your comments about the bidirectional relationship between cardiovascular and kidney health. It isn't, as you pointed out, just a matter of getting people screened for kidney disease. That's important. That is the focus of our call to action. But very importantly, we need to bring people the other direction as well, because as Elizabeth Montgomery showed so plainly earlier, there's such a strong not only connection, but we know that when people have kidney disease, their cardiovascular risk rapidly and strongly increases. So thank you. And your point too about having great new therapies is very important. The innovations are exciting. Oh my gosh, that last graph that Elizabeth showed of a greater than 25-year gain in life expectancy, it's massive, it's exciting, it's compelling. But as the Surgeon General C. Everett Koop famously told us, medications only work if people take them. And people can only take them if they have access to them and if they know that it is appropriate for them to take them. So we have our work cut out for us, but I think we do have a path forward here. So thank you very much, Rob, for your questions. And again, thank you for joining us. I'd like to ask the panel members to come back on if you're able to, so that we can take a couple of more questions in the remaining time. While you're doing that, I'm going to ask my teammates to put in the chat a link to an evaluation for today's convening. I would appreciate, I will be grateful, as will my teammates, if you'll take a moment now to click on the link and complete the evaluation, because your feedback helps us make these convenings valuable to you, and the feedback you provide today will help make the next one even more valuable for you. So please take a moment to do that. If you don't do it now, we'll bug you to do it later. So just go ahead and get it over with.
If I can add one thing while people are talking, waiting to put their questions in or typing.
Yeah, please.
One of the things that we're getting more interested in, we've started to have a lot of internal discussions and with our federal partners, is actually going even upstream of the upstream that you're talking about, of going upstream to people before they hit that GFR 60 threshold or albuminuria threshold. Because to me, there's a vast number of people who very simple things, and the internist on the call alluded to this, just not taking that fourth nonsteroidal or that second nonsteroidal may actually be really important. So for us, there's this whole kidney, we're calling kidney desert, where it's before anybody's even thinking about a diagnosis of CKD, but people are already on the decline, their kidney function's declining. But before they've hit the magic threshold, to me, that's an area we are beginning to think about next.
Yeah, thank you very much for that. Love the nudge to go even further upstream. Primordial prevention is where my heart is, so that's great. And Michael C. Dropped a comment into the chat that's right on that topic, urging more on prevention through lifestyle, because this is the most effective and economical approach. Absolutely, it needs to be lifestyle and the vital conditions for health and well-being coming together with healthcare to enable more people to attain better health. So thank you both, Rob Starr and Michael C., for that or those comments. I want to come back to a question from Warren Jones, who said, as someone who personally experienced medication-induced CKD, how much emphasis do you place on longitudinal monitoring for patients with episodes of medication-related CKD? I see Rob Starr and Randall Maxey both nodding. I think you're ready with a response. So, Dr. Maxey, if you want to lead off.
Well, I think that medication-related CKD, we have to look at the things that cause that. Nephrotoxic drugs are very important. In fact, we have a high sensitivity for these NSAIDs and other nephrotoxic drugs. We know that we need adequate hydration as well. And I urge people to look at the amount of protein that they use as they progress towards that. So we have to be sensitive about all of that. I'd be concerned about the use of certain antibiotics as well. So we have to have good advice from our primary care physicians as well.
Thank you. Rob, anything to add?
Agree completely. I overdosed myself on nonsteroidals and had a decline in GFR that then came back. So yeah, this happens even to people who know what they're doing. Wow. I think it's tremendously important. The monitoring is a really tricky question. We're beginning to see some home creatinine tests out there. Creatinine is very difficult to measure in the region that we're talking about, where it's relatively normal. Small changes in creatinine imply huge changes, bad usually for kidney damage. So I think, and there are lots of research level biomarkers for injury to the kidney, for acute injury to the kidney that are still in the process of being developed. So yeah, it'd be nice to have, urine dipstick or something to tell you overdid it, time to back off.
Dr. Clemmer, can I just speak to the specifics about the testing? The federal government hosts an online website called Healthy People 2030, which looks at markers for overarching health that the government wants to prioritize. And one of them is around acute kidney injury. And the data that's available on Healthy People 2030, which I looked at maybe a couple of weeks ago, suggests that only 10% of people who have experienced AKI actually receive the follow-up screening for kidney disease 90 days after the acute kidney injury to determine whether or not the kidney injury has resolved. So we agree 100%.
Say that number again, Elizabeth.
90% of people do not receive the follow-up, the recommended follow-up at 90 days to confirm that kidney function has a return to normal. So when the National Kidney Foundation is working on its screening work or in primary care settings, we try to emphasize the absolute importance of ensuring that people are tested per guidelines so that you have the ability to assess whether it's resolved or whether it has now moved into chronic kidney disease, and can implement care, appropriately. So it is a significant gap that we are also working to close.
Thank you for that. As you were giving those figures, you reminded me of Ben Blummel's phrase earlier, imagine if. And I've been doing that throughout your comments today, thinking about where we are right now with only 10-ish percent of people with hypertension being screened properly. And then in contrast, what pro healthcare in Jen Koberstein's home state with her organization's assistance has achieved. I mean, they're at 65%, and pro healthcare isn't. They're way above that. But statewide, you're at 65% and wanting to go higher. And imagine if we as a country achieved that kind of success. Imagine how many more people would be in that part of the graph that Elizabeth showed earlier, attaining the 25 additional years of healthful life. And imagine not only the social and familial benefits of that, but the economic benefits that everyone would enjoy. So imagine what we can do together. That leads us to a very important question that Rob Starr asked earlier. Rob, I saw your hand, but you asked such an important question. I want to make sure that we get to it in our remaining minute or so here. You pointed out that many people with or nearing a diagnosis of kidney disease are outside of the healthcare system. We've been talking a lot about health system change today, but you asked importantly, how do we include those people outside the system in our plans for screening, early detection, and treatment? I know our time's extremely limited, but Jen, Ben, Tiffany, if you have any thoughts to share in 30 seconds or less each, that would be great.
We serve the people outside of the system because that's what we represent. So I would say that actually working with in community organizations, pairing together, working together would be the ideal thing to do because building trust is important. The reason why those communities are outside of the system is because the system doesn't represent them. The system has kicked them in the face at least 100 times. And so now trust is not there. We've managed to build trust across the 150 counties, but it took us 8 years to do it. It wasn't an easy thing to do. And you can't just put a black face on it or a Hispanic face and walk into a church and do that. You actually have to relate to people and get into communities and build trust. So work with the people that already have done that.
Yeah. So community health workers come to mind here. Jen, Ben.
One liner, align the incentives, improve the outcomes, control the costs. And those incentive alignments, get them right for patients, for all of the providers involved, and for all of the payers involved.
Beautifully said.
I think it
Jen
was
Covers.
all well said. We're leaning hard on community health workers here in Wisconsin, on peer specialists, on people in the communities, working together to impact those, communities that are underserved, and highlighting that in all of our data work, making sure that when we do quality improvement work, we don't increase disparities.
Thank you
Can I
very much.
just add on one more as if or imagine if one more imagine if this discussion was about kidney health and not kidney disease. That's the science that we're trying to promote.
Love it. And that kind of orientation, where your North Star is, matters. So many things stem from it. So, Dr. Starr, that was a fantastic last point. Thank you for that contribution. I want to thank not only Dr. Starr, but our terrific panelists today, Randall Maxey, Elizabeth Montgomery, Jen Koberstein, Tiffany Jones Smith, and my brother from another mother, Ben Blummel. Really appreciate all of your great contributions today, your insights, your perspectives, as well as your questions. Thank you so much. And thanks to the National Forums team who did a tremendous amount of work in the background, been terrific. Julie Harville, our operations director, who took the helm of organizing this meeting, taking it from a kernel of an idea to the convening that we've experienced together. Thank you so much. Thank you to Sunny Shu, to Whitney Weber, and to our great producer, John Barkus, for your great efforts. Thanks to Jen Childress, our head of programs, for your terrific contributions to this. And thank you, most importantly, to everyone who participated. The insights that you've shared today will help shape the next phase of this work as we refine the call to action and continue building collaboration across sectors. Again, please use the link to the survey in the meeting chat and fill that out. And please watch your inbox for a message soon seeking additional input, feedback on the call to action. When you signed up for this meeting, when you registered, you automatically registered for the second convening as well. It's tentatively scheduled for April 30th. We understand that there is another meeting of stakeholders who are working on the same issues, the same challenges on the same day. And so please watch for a possible change to the date. We aren't sure yet how we'll work that out, but the National Forum was built to play well with others, and part of playing well with others is to avoid collision courses. So please watch for updates on that second convening. We are very eager to have your participation in it. Thank you, Laura Gordon, for your great work in the presentation of the call to action. And thanks, of course, to Beringer Ingelheim for making your participation, our participation in today's convening available to all of us without charge. And thanks most importantly to everyone who participated and for the work you're doing to advance kidney. Dr. Starr, apropos of your words, to advance kidney and cardiovascular health. With that, we are adjourned.